Welcome to the Managing Safety in Crisis Situations webinar. My name is Leslie and I'll be your operator for today. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I'd now like to turn the webinar over to Ms. Tracy Williams. Ms. Williams, you may begin.
Hello, everyone. Thank you for participating on this call. We will discuss managing safety in crisis situations, and Dr. Tom Freese has agreed to provide all of his expertise, so we're definitely happy to have him here. Additionally, this is a 1-hour presentation. There is an opportunity for any to ask questions. There's a Q&A feature that's on the desktop. And then there will be opportunities throughout the presentation, and you will be given instructions on how to do so. So I turn this discussion over to Dr. Tom Freese.
Hello, everyone. I'm really happy to be here today. I've been working with the CTN since its inception, and in fact, I did the original protocol training on CTN 001 and 002 nearly a decade ago now. And one of the issues that comes up frequently are issues of managing clients when they come into our research studies or our research settings and they're having a crisis of one form or another. Crises can take a number of different forms, from suicidal or homicidal behavior to aggressive kinds of behavior, as well as those clients who want to cross professional boundaries in a variety of different ways. So over the next hour, we'll have the opportunity to talk about many of those situations and strategies for handling them in the context of the research trials that you're operating. This is not a session on reporting of adverse events, although many of the things that we're talking about rise to the level of an adverse event that may need to be reported routinely or in a more urgent fashion. The reporting of adverse events is dictated by the protocol as much as anything. So we'll talk about issues in general, not specifically how to handle them in the context of any particular protocol. As Tracy said, we will have 2 question and answer periods along the way where we'll open up the lines for people to be able to ask questions. But if you have questions about content that we're covering along the way, please do use the Q&A feature, and Tracy will help to interject those as we go along. So today what we're going to talk about first is how to handle a participant who comes in expressing either suicidal or homicidal behavior. We'll talk a little bit about managing psychiatric and other drug use and the behaviors associated with that during a clinical trial. And then we'll end our session today by talking about identifying and reporting or responding to boundary violations in a way that it sets the limits appropriately but increases the likelihood that the person will not feel rejected in such a way that they'll pull out of the trial and can continue their participation in the research trial. My system is responding slowly. So first of all, handling suicidal and homicidal behavior. When you have a client or a participant who's in crisis, there are a number of things that need to be considered, and considering them in the right order is critical if we're going to manage the situation as safely as possible. So first of all, things that we need to consider are you safe, first and foremost? Next, are other clients who are in the research environment safe? Then, is the participant themselves, the one who's having the crisis, they're safe? Are you the most appropriate person to handle this particular situation? What other resources do you need in order to handle it effectively? And then after it's all over, these are really stressful situations. So how do you decompress after it's over to learn what you can learn from it, but also to make sure that you don't go home carrying the stress associated with handling a crisis in this nature? We'll cover each of these in turn and then have an opportunity for discussion. So first of all, are you safe? It's really critical to remember that your safety comes first and foremost, because protecting your safety is protecting the safety of the participant. If they're allowed to act out in some way and you end up getting harmed, that person certainly will be discharged from the trial, but also may face other kinds of consequences in terms of expulsion from treatment, in terms of potential criminal involvement. So protecting your own safety is in the best interest of the person who's experiencing the crisis. Also remember that if they hurt you, they won't feel safe any longer. It's an exercise of power that will leave them feeling even more vulnerable, because if they can hurt you, who else can they hurt and who's going to protect them? And like I was talked about, they'll no longer be able to receive any services in your agency, most likely, not just the research trial, but any other treatment services that you may be offering. So putting your safety first is in the best interest of the participant in the research trial. One thing to consider when you're looking at your own safety is, where are you in the office? And that really is a matter of what are your exit routes. More often than not, offices are set up in such a way that the door is on one side of the room and the desk is as far from the door as is possible. Generally, our offices are pretty small, and it's the most expedient way of setting up the office. So the counselor generally sits with a client or the participant between them and the doorway. Well, some people think that's an okay idea because the client can get out if they want, but the client can also block you from getting out if they should become agitated in the particular situation. So thinking about how are you going to change this situation so that you have the easiest access to the door becomes really critical. The simplest solution is, I can't get my slide to advance, there. Simply change positions. It's interesting what it does both to the power differential as well as your own safety to put the participant in your chair and you sit in the participant's chair. Generally, you're giving them a more comfortable chair, but one that's further away from the door. The other thing to be conscious of is, how are you going to ask for help if you should need it in this situation? If you're concerned, for instance, about a client who may be becoming aggressive and or may be experiencing suicidal ideation, asking a colleague to sit in with you and or leaving the door open may be one way of doing it. But does your office have a panic button in the context of the office? Many in research environments don't. So is there a phone in the office? If there's not a phone that's directly connected to reception, for instance, do you have your cell phone with you? What is a way that you could call outside of the office for help? And remember, in the worst case scenario, if you feel like your safety is in immediate jeopardy, just screaming out and calling for help may be the best course of action in order to alert people in the immediate environment that you are in need of assistance and that they shouldn't wait to come and provide it. Your personal style also becomes really important in making sure that you manage your own safety. It's really easy in the context of these situations as a participant is escalating to begin to mirror their emotional state. They start being mad and aggressive toward you, and you start responding defensively in kind. What this does is has a tendency to escalate the situation more and more rather than to calm the situation down. We need to watch our body language very carefully, and one of the things that very often happens in stressful situations is we have a tendency to lean forward, to move our shoulders forward, to move our bodies forward, which in sort of the animal part of our brain, we respond to as an aggressive threat. So the more you can move back and away from the person who's in crisis rather than forward and toward and certainly over the person that's in crisis, the more likely you are to be able to calm the situation down. The other thing that's really important to note is just your own responses to stress. What does your face do if someone makes you angry? What does your body do? And knowing those and watching for signs that you're displaying that toward your participant can go a long way to making sure the situation's calm. A piece of homework that you can do if you're not aware of how your body responds to stress is to go into a room with a mirror where you can have some privacy. Often it's the bathroom. But if you have a full-length mirror in your bedroom or whatever and can have some privacy, close the door, stand and look at yourself in the mirror, just sort of get a good impression of how beautiful you are and how great you look today, and then start thinking of every relative who's pissed you off across the course of your life. What will happen is you'll begin to see the markers of stress begin to form across your body language. Paying attention to what those are and noting them, you can begin to notice that if you're displaying it in the consultation room. For instance, when I'm stressed, the corners of my eyes pull back really, really slightly, changing and causing a wrinkle both at the side of my face and in the center of my forehead. That is the sign that I've moved into a stress kind of situation for me. So if I feel my face doing that, I need to take a few deep breaths, calm myself down, because I'm moving into stress along with the participant. So our goal is to stay calm and keep a low tone of voice and a soft speaking style, even in the face of a participant who may be verbally escalating, getting louder, getting more aggressive in their personal style. And we covered that one. If none of this works, it's time to take a break. And figuring out how to get out of the room in the least dramatic way is what's important. So simply suggesting taking a break, going out and getting some water, maybe having a restroom break to de-escalate the situation. You getting up and leaving the office, even if the person gets aggressive, you're not in the office so that they can't get aggressive toward you. And finally, if need be, leave the building along with everybody else. It's much better to have a few broken pieces of furniture, for instance, than it is to have a few broken pieces of people. So exiting the situation becomes really important. And finally, we want to consider sort of that maybe the situation has escalated beyond our ability to handle it independently. So knowing who the supervisor is on duty and or how to get a hold of your supervisor to ask for help in de-escalating the situation is critical. Knowing who else is in the immediate environment and asking a colleague to assist you in the situation and or to take over the situation if you feel like you can't handle it, may be another way of de-escalating the situation. And remember, if the situation is completely out of control, we can always call for outside help, including the police. It's really important that you don't necessarily, unless it's a critical life and death situation, that you seek consultation within your agency before reaching outside of the agency, if that's at all possible. Lots of times a situation can be de-escalated by someone who just has a different perspective without needing to involve the police. But if it's critical and the situation is out of control, engaging whatever authorities are needed in order to get it into control is really important. So keeping yourself safe is keeping the participants safe. The next in line is keeping other participants in the environment or other clients in the treatment milieu safe from whatever situation is going on. So consider, where is this situation happening? Are you in a private consultation room, or are you in the lobby with a whole bunch of people watching? If other participants can observe what's going on, they may not feel safe. They may want to help in the situation, and we want them to feel safe in our environment. We don't want the chaos of their lives coming into this place where they're coming for help or for participation in our research trial, and we want them to feel safe continuing to give us their data. And so if they feel like the office environment is too chaotic, they're not going to want to continue to participate. So we want them to have confidence in the environment, confidence in you, and an environment that's free from chaos. Likewise, One client having a crisis is likely to lead to another client having a crisis. Many of the people that we work with in our research trials come from fairly unstable situations, and so simply noting that someone is escalating out of control may stimulate a similar response in another participant. And so by removing the situation and making sure that it's not visible, we may prevent multiple escalations at the same time. So we want to remove the participant who's having the crisis to a quiet, safe place, away from the peanut gallery, as it were. This will help to calm the participant. It'll help to calm you and make sure that you're not feeling scrutinized as well. It will help to protect confidentiality. We know that participants can say whatever they want, but we can't. But in intervening with a client, we may inadvertently say something that really is a violation of their confidentiality. By making sure we're in a private space, we don't need to worry about that. And finally, if the situation escalates into an aggressive form of interaction, it'll protect other participants and clients in the environment from any sort of direct harm, from, a pen being thrown to a chair being overturned or any other sort of aggressive acting out. And finally, as well-meaning as they are, the little darlings are not so helpful sometimes. And what we don't want is other participants getting involved in trying to help us out and thereby escalating the situation. And so by removing it out of the view of other participants, we're preventing those other participants from helping and inadvertently making the situation worse. So finally, after considering our own safety and other clients' safety, we get to the person who's in crisis. Very often, people feel like this is upside down. If someone's in crisis, we need to focus all of our attention on them immediately. But as you said, for all the reasons that we've discussed, that may lead to us making the situation worse and not better. When we turn to the client who's in crisis, the question is, are they a danger to themselves or are they a danger to someone else? Are they just having a bad day and that's the crisis, which means they need to talk to someone or they need to be diverted to counseling, or are they really escalating to the point where harm is going to come to someone? We need to define this danger very, very carefully. If danger means they're likely to be aggressive, we want to follow the recommendations above. Remove them to a quiet place, help to de-escalate the situation, use a calm and quiet voice, calm them down if that's at all possible, engage other resources if it's not. If danger means they're going to kill themselves or someone else, we have to follow all of those recommendations and make sure that the individual gets assessed appropriately for their level of risk in carrying that out. We've now moved from a simple client interaction kind of issue to a medical legal responsibility in which we now become responsible for ensuring that we do everything that we can to care for the safety of that individual and to make sure that they don't kill themselves, and to care for the safety of an intended victim if they are intent on harming someone else. So I seem to have missed a slide in there. In doing an evaluation, let me try one more forward and see if I just have them out of order. No, I didn't. In doing an evaluation of their level of danger to themselves or to someone else, it's important to pay attention to your own level of expertise. Are you clinically trained? Have you been trained in doing assessment for suicidal or homicidal behavior? If the answer to those questions is no, you're not the right person to make the decision about the overall level of risk. So in our research protocols, there is someone on your team who's been identified as the clinical manager of these kinds of issues. It's critical to know who the medical director is and or the clinical director is in each of your protocols, and whenever possible, hand this stuff up to them. In reality, what that does is it makes sure that the participant is getting the best level of service possible, and it protects the entire organization from making a mistake by not handling the situation in the most appropriate way. A number of different possible outcomes may result from this kind of reporting. One, the person just may say, yeah, I'm just having a bad day. They may deem it as being fairly low risk, and no additional action is recommended. They may be deemed as at some risk, and there may be some contracting that happens about promises to get help if it rises to the level of crisis, or it may involve calling the authorities and having the person placed on an involuntary hold and taken to a psychiatric emergency center. I've done probably hundreds of these evaluations, and I never do one without it causing a great deal of anxiety for me, even though I'm specially trained in this area, about whether I'm making the right decision and about whether or not I'm maximally caring for the benefits of the individual. If you're not trained in it, it can only cause more anxiety, and so it's important to pass it uphill. If you feel like, if you're waiting for your supervisor, however, the person you're going to pass this to make those kinds of decisions, there are a few pieces of information that you can get that will be very helpful to the clinical supervisor when they come in to assess the situation. And that is, do they have a plan for what they're going to do? What specifically is that plan, and what's the method they're going to use to kill themselves or someone else? And how serious are they about carrying out that plan? The other thing you can check on is what kind of resources do they have for themselves that they can draw on to get support to help alleviate that crisis. Is there a friend or a family member that they could go and stay with, for instance, that would help them through this crisis and reduce the likelihood that they're going to follow through on killing themselves or someone else? Even though it's not our official question and answer time, Leslie, I think I'd like to open it up for a minute and see if anyone has any questions or points of discussion specifically around this danger to self or others issue.
Thank you. If you'd like to ask a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset before pressing the numbers. So once again, if you have a question, please press star, then 1 on your touch-tone phone.
Any comments or questions about anything?
I have a question or comment from Christy Thomas. Please go ahead.
Hey, Christy.
Hi, Tom.
Hey, Christy.
Hey, so along the lines, I guess one thought that I had, sometimes staff sort of in the idea of exploring as much information as you can so that you can pass that information off when the qualified clinician comes in. Yep. Can you talk about the reluctance that sometimes people have in getting detailed information, thinking that it might cause the person to really formalize that idea, it might cause them to act by sort of having them really to talk through what their plans might be?
Thanks, Christy. I appreciate the question. You know, it's really interesting that in all of the evaluations I've done of this nature, it is actually relieving to the individual to have someone to talk to about it. Remember, if they bring it up, they've already been told about the limits of confidentiality. So if they wanted to carry it out without anyone knowing, they would keep it to themselves and they would carry it out without anyone knowing. So by virtue of the fact that you suddenly know about it, we can interpret that as a plea for help on one level or another, whether they're conscious of it or not. And so what happens is we talk to them about it and hear what they have to say, and they're either disclosing what's already in their mind, or they're sort of becoming clear on what they're already thinking about. There is no possibility that you will plant the idea that it would be great to go home and kill yourself if it's not already there in the individual. And so by talking about it with the person, we're able to elucidate the reality of that person at this particular time and get them the help that they need. But we don't need to fear precipitating a worse crisis because the crisis is already in the room. It resides in the participant themselves. By knowing about it, we can do something to prevent it. By being afraid to talk about it, we tie our own hands and we may let that person walk out without ever being evaluated effectively. The other thing that's important to remember is they're talking to you for a reason, and that means that they already probably have some trust and relationship with you. They may be really nervous about a new clinician coming in and talking with them. So they may be willing to disclose to you, but really afraid about talking to someone else. So getting this information can help the clinician who they haven't met or have a limited relationship with get an accurate picture of what's going on, and then you can remain with them while the other clinician is evaluating them to both help fill in information that you've heard, but also help the participant feel more safe. Any other comments or questions?
I show no further questions or comments at this time.
Great, thanks, Leslie. Thanks for that question, Christy. So we want to be watchful in our clinical trials, not just for this, these kind of aggressive or suicidal or homicidal kinds of behaviors, but we want to look for risky signs that are associated with just their general lives and certainly with their participation in the trial. You'll be given a list of sort of known side effects, for instance, that we want to watch for if we're trying a medication. We also know that it may lead to a recurrence of risk that we hadn't ordinarily interpreted. For instance, in a study looking at reductions in opioid dependence, we want to watch for increased opioid use, which may interact with the opioid medications that we're using. We want to watch for increases in injection drug use. We want to watch for symptoms, for instance, with a blockade medication that they may be using trying to overcome the blockade, or that they're using at a level that's compounding with the medication that they're on and showing signs of over-intoxication or overdose. So looking for those things that are likely to occur in our patient population and are associated with our research intervention becomes really important. We want to pay attention to how they're functioning on a day-to-day basis. Someone who comes in and they're particularly confused on a particular day, often we'll just dismiss that and say, oh, look, Bob is having a bad day today. But that may be a sign of a new or emerging psychiatric impairment that has been previously unidentified and or may be associated with the research intervention that were conducted. So paying attention to their day-to-day functioning and documenting that along the way becomes really important. Likewise, we had a client who suddenly sort of went on shopping sprees and was dodging in and out of traffic, crossing the streets, busy streets in the middle of the block, and had never done anything like this before. Well, he was showing early signs of a manic episode that, had we not been paying attention to what really started as some soft signs of playing chicken with a car by jumping in front of it, looked like suicidal behavior. Was it? No. Turns out it was manic behavior that we were able to then get him a referral for. So if you notice something, pay attention to it and bring it to the team's attention. We want to look for evidence of medical deterioration of any sort. Are they having medical problems that we haven't seen before, showing new medical issues, or just the onset of any other condition? Again, we know some things may happen, but we don't know a lot of things that may happen, and we may find a new side effect for a medical intervention that we haven't seen before, and or may just be able to save someone from detrimental consequences as a result of the chaos that's going on in their lives. So if any of these situations occur, we have to notify the medical clinician over the study for them to be able to evaluate and determine the most appropriate course of action. We want to pay attention to our study assessments. We want to routinely do our adverse events and serious adverse event reporting. Again, this is a way of monitoring the safety of the individual. It's important that we do them in real time according to the protocol, not in retrospect according to our memories, or we're not getting a good read on what's going on. And it's kind of unethical research practice. So for all of those reasons, we want to make sure. Every I believe that every CTN trial has some assessment of the level of depression and or for suicide and homicide. In a study that we did recently, for instance, I think it was the POST study, we used the PRISM, but there are a number of others that are used. If those measures are administered, it's important to pay attention to them, to know what a positive result is, and to know how often that they're administered so that we can monitor not only the verbal discussion that we have, but also the research data that we're collecting. All of our research trials use an inventory like the Beck Depression Inventory or the HAM-D or a number of others. Again, there's a direct question in each of those trials about suicidal ideation, and if we don't pay attention to those and we simply see them as another form, we may miss an indicator that doesn't come up in any other way. And then utilizing timeline followbacks to look for increases in drug use, as well as other safety behavior that may be monitoring on those is critical, again, in the overall safety monitoring of a participant's course through the research trial. I left a couple of old slides on the PRISM in there. I'm not sure why. But again, with Beck Depression Inventory, which is, I think, the most common one, knowing where the person is on the score, whichever depression inventory that you're using, is really critical. If you see someone who has routinely been scoring in mild depression, and they start creeping up toward that moderate depression level, for instance, they may not be at the level where it is diagnosable and or even reportable according to the study protocol, but you may be seeing early signs of a crisis. And so for research assistants to note those scores and to be able to bring them to the clinical team as appropriate becomes really important. Again, may not be reportable, may not be an adverse event, may not even be indicative of anything, but it could be an early sign that some problem is going on and needs additional intervention. So if someone does report that they have a significant risk of killing themselves or someone else, they may need to be hospitalized. In most places, if there's a psychiatric emergency team in the local jurisdiction, you call the emergency number and they'll send out the psychiatric emergency team. Across the country, most jurisdictions have eliminated those PET teams as the first responders because they're really expensive. And as often as not, when you call 911, they'll send out the police officers first, who will evaluate the situation and then connect them with psychiatric emergency, either by transporting them to the hospital and or by calling out the psychiatric emergency team as indicated. It's important that this be done in as safe and as quiet a way as possible. There's nothing that's more unsettling for a group of participants in a research trial where they're talking about their drug use than to have a herd of police officers suddenly walk through the waiting room, for instance. So if you have the back entrance where they can come in quietly, if you can keep the situation contained and off to the side and out of the view of most participants, again, you're increasing the likelihood that other participants are not going to feel threatened by that situation. If you haven't done this before and police officers do respond, it is not uncommon for them to handcuff your participant. It's a way of securing them and making sure that they don't act out of control. But generally what I'll do is not necessarily tell the person that the police are on their way until they're basically right outside the door. And then I'll inform them as they're coming in and that I'll stay there with them. The police may ask you to leave the situation, but someone on the research team should remain with them at all times, and you have a right to do that while they're on the premises with you. If the risk is less, the clinician will work with them to develop a plan for how to make sure that it doesn't become worse. This generally involves developing some sort of contract, including promising not to harm themselves or someone else, and promising to call for help if the crisis gets worse. Who they call, again, will in part be determined based on the protocol and in part be determined based on the structure of the research environment. If, for instance, it's an active clinical site, it may be that they call the regular emergency number that other clients in the environment may call. In other kinds of studies or during follow-up periods, it may just be a promise to call 911 if the situation gets worse. Know what the protocol says about how to handle that, and know what your local policies are so that you have all the tools at your disposal. Again, it's important to remember that you should only be making this decision if you're trained and qualified to make these decisions, and therefore it's important to get what information you can, but to pass it up to the clinically trained people if that's not you. Which gets to, can you handle this situation? Do you have the skills? Do you have the training? And are you confident enough? Even if you've been trained specifically in suicidal or homicidal assessment, there are situations where you just go, dude, this is way above my head. I'm not sure how to handle this one. Know that, note it, ask for help. It is a sign of strength, not a sign of weakness, to know when you're in over your head and to seek out the help that you need in order to make sure that the situation is handled as effectively as possible. So know when to ask for help and know who to ask for help from. Again, you know, these crises always happen on a Friday afternoon after everyone else has gone home and you're the last person there with a colleague who also isn't trained on how to handle a particular situation. There's still someone who's responsible for that, and knowing how to get a hold of that person to help you handle the situation is imperative. What other resources do you need? So who's in the immediate environment in order to ask for help for the crisis? Make sure, this is one of the reasons why we want no one to ever be alone in the research environment when participants are present, because it's critical to have someone there to help if situations arise. Are there other staff, for instance, if you're in a research group and you're doing whatever's going on and a crisis erupts in group, are there other staff who could take over the group while you handle the client, or take over the client while you continue to handle the rest of the group? Again, as a way of separating the situation. And do you need to engage medical personnel? Remember that it gets easier each time that you do this. And fortunately, it doesn't come up very often. You know, talking about this stuff often creates a great deal of anxiety, but in our research protocols, I can only think of a handful of situations where we've had to seriously engage other outside help in order to deal with a particular situation. Usually the crises are much smaller and can be handled by staff in the immediate environment. And then finally, each of these situations is a good learning environment. It's essential that you talk to your supervisor and other colleagues about what went well, as well as what you could do better in the future to improve both your skill and confidence and your ability to handle this situation should it arise again. The best way to burn out on this kind of work is to find yourself in over your head again and again and again without growing from the situation, learning from the situation, and decompressing after the situation occurs. It's a skill that involves talking to other people in order to learn that skill. So it's important to take advantage of those opportunities. All right, Leslie, we've come to our first official question and answer period, so I'd like to open it up again.
As a reminder, if you'd like to ask a question, that's star, then 1 on your touch-tone phone. We do have a question from Christine Higgins. Please go ahead.
Hi, Christine.
Hi, Tom. I have a question about what you were talking about earlier with our own, body language and facial gestures. Any cues that come from the participant? Is it wise to, have some, for example, the participant should suddenly stand up, or or make an aggressive move like, pound the desk. I mean, should we consider those warning signs, or is that not the best?
No, that's an excellent question, and I feel like I understand the thrust of it. So see if I get it. we want to use all of the information that we have in the room. Certainly a participant who's red in the face is giving you information about how they're feeling. Their color of their face will also give you information about how they're experiencing you in the environment. So the first question is, could I take a couple of deep breaths and back away, and will that lower the color of red in my participant's face? If the person suddenly stands up, now they're looming over you. We have a few options, but one of the options is to really, again, maintain as much calm as possible. If they're not coming at you, ask them to sit down again. You know, I understand that you're upset. Will you please sit down again so that we can talk about it? If they don't, it's time to leave, because they're now actively engaging in aggressive behavior. Pounding the desk. Again, you know, I appreciate how upset you are. Using some of those basic motivational strategies. I see that you're really upset, and I want to help you with that. I'll ask you not to pound the desk, but let's talk about it and figure out how we can help you through this situation. They keep pounding the desk. Again, it may be time to take a break, to de-escalate the situation, and or to ask someone else to come in and help with the situation, because it's clearly escalating, not de-escalating. Did that help?
Yes, very much.
Perfect. Are there other specific examples that you'd like to talk through?
No, not for me. I just was wondering whether, it was, I know sometimes people can just be very non-emotive.
Right.
That might also be a cue. So I was wondering, when is it, but I get, your response, which is almost kind of have a gut reaction.
That is the best advice that I can give anyone ever, which is your gut is telling you something. If you feel unsafe, you probably are. So the question is, what's going on that's making you unsafe? Do you just feel like you don't have the skills to handle this instrument that's in front of you? That can make you feel unsafe and make you feel a little oogie. We need some more training. Do you feel like you don't have the skills to handle the information that the person is telling you? Again, supervision and consultation. Or do you feel like they're aggressive toward you and they're directly threatening you? That's telling you it's time to have a sort of a potentially flight response if you can't de-escalate the situation. Mm-hmm. So we use our gut for information, and we use the participant as a mirror for what's working and what's not. And for whatever reason, if you're seeing signs of continued escalation, not de-escalation, something isn't working, and it's time to engage additional resources.
Great.
Excellent question. Thank you very much. Are there others?
I show no further questions at this time.
Great. Let's move on to the other elephant in the room then, which is boundary-related issues, I believe. Oh, I'm going to skip over these because we covered them all. So identifying and responding to boundary violations. Because what we talk with our participants about is really personal. Even if we're only talking about their drug use, we're asking them to disclose illegal behavior. But we often talk about a lot more aspects of their lives than simply their drug use. So they may want to push the boundaries for a number of different reasons. One, if they can suddenly make you feel uncomfortable, they can divert attention away so that they don't have to answer your nosy questions. If they suddenly can sort of begin pushing those boundary violations, they change the power differential in the room so that suddenly you as the interviewer on the spot, you're the focus of attention both for yourself and the respondent, as opposed to them being the focus of attention, which is what we want to have happen. And finally, if they're really uncomfortable and they don't know any other way to get out of this interview, they may push the boundaries as a way of ending the interview by, suddenly engaging in grossly inappropriate behavior, which forces you to put an end to the behavior. If we can watch for those early signs, asking too personal a question or sort of encroaching on your personal space, and we can set limits there, we often prevent those gross violations of boundaries that happen subsequent to those. So the first question is, when is self-disclosure okay? Is it okay? I mean, do you have to never say anything about yourself? How was your weekend, Tom? I can't answer that. It's self-disclosure. Are you married? Should I answer that or should I not? What does it mean? What do you like to do in bed? It's another question that I've been asked by a client. That one is clear. I should never answer that question. So if it's a grossly inappropriate question, it becomes really easy whether or not we should answer it. It's the more subtle stuff that then raises the question, should I self-disclose or should I not? There isn't an absolute answer to this, but there are some guidelines that you should consider when considering self-disclosure. First of all, why are you disclosing this information? Is it really just a nicety? I had a good weekend. Do you really need to go into all the details of everything you did over the weekend, or should you just engage in pleasantries? Or are you feeling some need in yourself for connection that really should be met with your friends, not with the participant? What's the purpose of this particular piece of information that you want to disclose? What will the information mean not only to this participant, but to every participant in your research trial? Because disclosing to one individual is like playing telephone. You never know what the message on the other end is going to be, but every other participant that this person comes in contact with is going to have that information. So what's it going to mean to them, and what's it going to mean to every other person in the clinic? And do you want them knowing that? Is there another way to accomplish your goal without self-disclosure? Again, what did you do this weekend? Oh, I had a nice relaxing weekend, as opposed to all of the details. We've engaged in pleasantries. We've sort of welcomed the person and said, yes, I'm a human being, without necessarily disclosing all of the details associated with who you are and how you live in your daily lives. Why are you disclosing? I think I may have covered a lot of this. If you're going to disclose the information, are you sure that you're meeting a participant need and not a personal need? This is a really difficult question to tease out, but it's a really important one to ask yourself. Why are you disclosing this particular information, and what is it? Asking yourself the question, what does this do for me, regardless of what it does for the participant, can help you to begin to distinguish the answer to that question. So if you decide disclosure is not the best thing for me to do in this particular topic area, there are a few strategies that you can use. First of all, you can deflect the question. This is the classic sort of counseling approach. What did you do this weekend? Well, that's a good question. What did you do this weekend? Bounce it back to them and see what they have. Or, let's move, we were short on time today. Let's move on to our questionnaires for the day and deflect them to the goal of what we're going on. If we can do that sort of naturally and comfortably, it generally doesn't seem off-putting. What we don't want to do is end up sounding defensive. Well, why do you ask? What did you do this weekend? Suddenly becomes an icky, hostile kind of interchange as opposed to simply an alternate to self-disclosure. We can redirect them to something else, as I talked about, redirect them to the form, redirect them to another topic area. We can answer another question. What do you like to do for fun? Well, I can think of lots of things I like to do for fun, many of which I don't want my clients to know about because I don't want them to show up there. So maybe we could just, saying things like, after work I like to just relax and chill out because, work is pretty stressful. Answer a different question than the one that they asked, but give them the flavor of the information that they're looking for. Finally, one of the strategies that I like to use is to answer in the third person. I talk a lot about myself and my friends and my family, but I do it in the third person, and it suddenly becomes not self-disclosure. So, well, have you ever used drugs? Well, I've worked with lots of people who've had these kinds of problems, and, in our experience, this is the kind of issue that comes up. We can talk about people that we know, talk about them in the third person. It makes it more anonymous. Those are the easy ones to deal with. But what if they want something a little more from you? What if a person wants to become friends with you, or they want to have coffee or dinner? The big question is, what's wrong with that? You know, the person's in the follow-up period for a research trial, and you show up at Starbucks, and the person is sitting there, and they invite you to join them. Can you sit down and have a cup of coffee with them? Well, officially and unofficially, the answer is absolutely not. The big question is why? Our relationship with these participants is unidirectional. It is about us finding out information from them about what works and what doesn't work in the context of these research trials. In more clinical settings, it's about us helping them with a problem that they have. In all of those relationships, it has nothing to do with us. And if we begin to form a more mutual kind of relationship, we confuse the point of the relationship that we do have, and we make meeting the goals of that point more difficult. So you sit down for coffee with this person who's in follow-up, and while you're chatting, you find out that they relapsed last week and that they're engaged in all kinds of risky behavior. They tell you this as a friend. Does this become research data? When they come into the program for their next follow-up visit and they say, no, everything's great, I'm doing good, no, haven't had any relapses, not engaging in any risky behavior, have a nice day. What do you do with the information that you have from your cup of coffee with them? It becomes a conflict of interest that is impossible to overcome. And so the general rule, clinically, is 2 years after they've left treatment, which with substance use, I say, is about 2 years after they're dead. From a research experience, I would just say we can't have relationships with our participants, period, ever. And if you find yourself in a situation 3 or 4 years after having a participant in a trial where that seems like a good idea, talk to a supervisor about it and really make sure that it's a good idea, because there's exceptions to every rule, but there are a few exceptions to this rule. What if they want to be romantic and or just have sex with you? Again, this is an extreme boundary violation. They may express this by touching you inappropriately and or saying inappropriate things to you, or just asking you out on a date. A lot of times this is about changing the power differential, as we talked about before, so it's a power play, not a romance play. But also, for many of our clients, depending on the nature of their relationships, they may not know how to interact with someone in a more collegial or friendly kind of way. If they like you, it means they have to have sex with you. And confusion of those roles and boundaries is something that we need to set really clear limits to. What's important in setting limits with any of these kinds of relationships is that we do it in as accepting of the participant as possible and as firmly as possible. You know, in one of my early research trials, when I was working as a research assistant, I was collecting baseline information about kids on the street, homeless kids, about their sexual and drug risk information. And I'd done this interview with a young person, and at the end of the interview, he said, "You're sweet and cute, can we have sex?" Now, one possible response is, that's not a good idea, or I'm not allowed. We set the rules in place to say, I can't do that. What's important to know is that every rule can be violated, and everybody knows that. So you say, I get in trouble. The person says, I won't tell. You say, I'm not allowed. No one has to know. You say, I have a boyfriend. Who cares, right? So every rule can have a violation. What we want to do instead is we want to make sure that we say to the individual, no, that's not ever going to happen, but I'm really interested in helping you in the way that we've negotiated. So we try to help them feel accepted in the way that we can, but set firm limits around the ways that we cannot allow the relationship to progress. I think I covered all those. So So we're almost at the end of our time together, but I would like to open it up one last time for any questions or comments before we close the session for the day.
And as a reminder, if you had a question or comment, please press star, then 1 on your touchtone phone. We have a question or comment from Christine Higgins. Please go ahead.
Hey, Christine.
Hi, I have another question.
Good.
I usually don't have direct contact with patients, but I train, folks who do.
Yeah.
And often, sometimes, women say between the ages of 20 and 30, and they'll tell me about patients who are inappropriate, who they feel are inappropriate, say, for example, by calling them babe, or by saying, when you're going to go out with me, just like kind of in a session or across the hall, and it makes them uncomfortable.
Yep.
And my best advice has been, it's the same sort of thing. You don't want to shut the person down, especially as you're asking them to participate in something.
Right. It's important to come up with a pat answer for those kinds of things. So the person who calls you babe, if you've noticed that becomes a theme that, hey honey, hey babe,
right.
It's nice to see you too. Please remember my name is Sarah.
Okay.
So set limits about how you'd like them to refer to you. And then the next time they say, hey, babe, pull them aside and say, I really am always really happy to see you, and I love it that you greet me when you see me in the program. But I really do need you to use my name and not some other nickname like honey or babe. I need you to call me Sarah, and I really appreciate you doing that.
Great.
So you're not rejecting them, but you're setting a really firm limit on what it is that they're doing. Hey, Sarah, when are you going to go out with me? I'm really glad you're here, and I'm never going to go out with you because that's not what we're here for. Let's take care of what you're here for today. So again, coming up with something that you can say genuinely that doesn't feel rejecting, but sets a really firm limit. My style is really, really super direct, and I can do that and not sound rejecting. Other people, if they did it, they'd have to do it through anger, and therefore they sound like they're pissed off.
Right.
Or they need to come up with another pat response that's prepared for them that will work in their style to not sound rejecting. And just working with the people that you train around coming up with those kinds of responses can be really helpful in alleviating the anxiety that will burst through when those things happen.
Excellent. Thank you so much.
You're welcome.
Tom, thanks so much. We are going to have to draw this to a close, but I would like to encourage everyone, if you would like to, in fact, send more questions, Tom would be very open to answering additional questions. You can direct them to CTN training at ms.com. Tom, thanks so much for this information. It was great.
Thank you, everyone.
And what I'd like to do is encourage everyone to go to the CTN Dissemination Library if they'd like to reference these materials, and also to go to the survey once you receive it, and please complete it. Thanks so much, everyone, for participating.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.